Hi,
Hello, Dr.
how are you?
Ghadir.
How are you?
How's it going?
Everything is going well. I'm glad we're able to make this happen.
Yeah.
I'm sorry that I'm sitting in my car, but I definitely was excited to talk, and I wanted to go over a lot of things going on in this world right now. A lot. How are
Yeah.
you? Tell me. Let's start with that. How are you doing?
I'm doing good. Just taking it one day at a time, trying to be malleable. I think that's the best thing that we can do now because every day there's a shift, every day there's a change. And so you have to kind of just figure out how to move with the punches, you
I know,
know?
I know. It's been a very challenging time, and to be really honest, got some feedback from patients and people asking questions about starting fertility treatments, and some things concerned me. And when I saw so many different posts about healthcare provided for the Black community that's different and with lower success and with more horrible outcomes, it really concerned me. And it's
Mhm.
something that I thought was really important for us to address.
Mhm.
Um, I've known you for a long time. You're such an amazing doctor and you do such an incredible job with your
Thank you.
patients. I thought it would be a phenomenal idea to try to address some of these things right now.
Oh, for sure. We had the conversation before. I don't know if you want to even share the exchanges you had with your patient, but essentially the conversation that we had was the level of concern from Black patients and the level of perhaps trust that exists, amongst
Yep.
the Black community and the healthcare community. And this is something that has been, an issue and really a gaping wound for decades. It's nothing that's new. It's certainly something that has been generational, and and with reason. Because I think that when you look at the history of things in terms of the maltreatment and the abuse of Black and brown people in this country, and certainly within the realm of healthcare, it exists and it's been that way for many years, and it does have an impact on our health and our health outcomes.
Yeah.
And just to give a little bit of history, because we can go all the way back to times of slavery to present, where there have been many accounts where Black people have been mistreated, and one of those being the Tuskegee experiment. I don't know if you're familiar with that.
I'm not.
Okay, so the Tuskegee experiment is actually one well-documented instance, which I think has had long-term effects in terms of how the Black community has seen healthcare in terms of being able to trust the clinicians across the board. And what happened during this experiment, which actually happened in Tuskegee, Alabama, at Tuskegee Institute, or Tuskegee University, which is an HBCU, historically Black college and university. This is where essentially over 600 African-American men were placed into this study to look essentially at the disease progression of syphilis. And they were not told why they were being enrolled. They were essentially told that they were being given free health care by the federal government. There was no informed consent, but that they were given free health care, right? And so what happened during this time is that the participants that were in this study were not told of their diagnosis and purposely not treated. And this is a study that went on for 40 years that was only supposed to go on for 6 to 9 months, okay? And this is between the years of 1932 to 1972, so it ended not that long ago. And as a result, even when treatment was discovered, which was only a few years after the start of this study, it was purposely withheld. And as a result, many Black men died. And as a result, many Black men gave syphilis to their wives unknowingly, and those women bore children with congenital syphilis. And within the Black community, we may not know the specifics of this instance, of this occurrence, but the effects of it, have resonated in terms of how the healthcare system is seen being a partner in health, which it perhaps is not that. And we can come to present, where there's been research that's looked at specifically the outcomes of African Americans and and people of color where there have been poor outcomes. And this is across the board and looking at all specialties. So there was a landmark study that was done in 2003 looking at all specialties where across the board that for African Americans, they were less likely to get procedures compared to other groups, and more likely to receive poor quality of health care, and implicit bias really being, part of one of the reasons that was felt that this was the results, and I think that's something that we really need to talk about in terms of what are the biases that we hold, right?
I think this is a really, really great example that myself, an educated person, doesn't know about this study. And it's sad.
Yeah.
But I think, getting back to one of the reasons I called you, Noelle, was when I got a call, my new patient coordinator said, I'm concerned to see Dr. Ghadir because I'm not convinced he knows how to treat women of color, is what he said. And she's actually a woman of color who answers the calls and takes care of everything, and said, I can guarantee you Dr. Ghadir takes excellent care of all his patients and definitely knows how to take care of women of color, as he has for many, many, many years. So this came to me, and just, there's a naivety that we have to clarify, and there is a level of knowledge I think we have to bring to the table as physicians and healthcare providers to make sure that every single patient of ours is treated in the right way and in the correct way. The study that you're citing is shocking, to be honest, and I'm embarrassed that I haven't heard about it.
And that's an issue, right? Because I think for us as clinicians, we need to know the history of healthcare. We need to know the history of the communities that we treat, because that's going to impact how we're able to address, every community openly, and with empathy, and understand when there can be issues with trust, right? Just being able to feel comfortable with being treated by someone who does not look like them.
Well, I think that the most important thing that you have to have with any physician is trust. Making sure that any culture and anyone being treated by you, especially women of color, trusts is very, very important. The other day I was doing a consultation, and it was a patient, a lovely Black lady, who called me, and she said, I don't know if you get it, but in my culture, going forward and using an egg donor is difficult because I wouldn't know how to explain it to my family. And I said, you know what? I understand where you're coming from, because I come from a different culture myself and a different background myself, but I don't want you to feel alone in this, because many women in your situation say the same thing. And it's sad because I felt like she felt a barrier and an extra level of kind of pressure on her going forward to use an egg donor, where if we had good communication and we had open boundaries and doors, and everyone understood and understood this on the same wavelength, that we would probably all understand that it's difficult for everyone.
Oh, for sure.
But I'd love some advice from you on a doctor who is not of color, what to do to make my patients that I care about dearly, and I want to make sure that they know that I'm there for them, whether I'm a different color or not. What would you suggest are important things for someone like myself to do?
Well, I think first thing to do is take a long look in the mirror, really do a good self-assessment and figure out, are there biases that I hold? Because I think the reality is we all hold biases, right? We're human. We're humans living in a world where we're influenced. We're influenced by our families, we're influenced by culture, we're influenced by society, by media. And so there may be biases that we hold that we're not even aware of, that it's unspoken, that there's, nonverbal cues that we're giving that the patient may actually be picking up on. And so I think doing a good self-assessment, is there something that is impacting the way that I see myself and I see others that can be affecting the way that I treat others? And moving from that, I think is just not being afraid to have an open discussion. So when a patient does present with you, hey, this is not part of my culture, I don't understand this, or I don't think that you understand me, take it back a bit, be willing to be humble and say, okay, I get you. I understand that. So let me see how I can understand you better, because you know what? I didn't even realize that is the case, that is not the norm for your family, or for your community. So let's kind of get to an even, playing field. And I think also too, and this is just for humans across the board, not just as clinicians, but for all of us to see each other as human. And so what I try to do when I have a patient that's sitting in front of me, I look at them as a family member, like maybe this could be my mom.
I always
this is my dad.
Always.
And when you see them that way, like this is my child, then that means that you're connected to them, so you're always going to want to do the best because there's a connection there. It's not that, this is this is something that you don't understand, something you're not familiar with. No, this is my family, and those, I think, are just some very basic things. But honestly, I feel that, as from a systemic standpoint, we need to be educated better, because I can't say that I never got a course in cultural competency as a med student. I never got a course as a resident, and that's an issue. That's an issue because we're not, incorporating that in the curriculum. And I think that's just as important as us learning, the very specific scientific methods and all of the very technical things that we have to learn as a physician. But at the end of the day, you said it earlier in our conversation, communication is what's important. A diagnosis can be made by a conversation. I don't even have to touch a patient in most instances, and I know the diagnosis, because you have sat and you've had a conversation, they've given you all the cues. But in order to get to that point, in order to penetrate that person, there has to be that level of trust, so that they're open.
Like I said earlier, one of the most important, I just feel horrible for patients that don't trust their doctor 100% and don't have a strong relationship. For me, the most important thing that I do with my patients is make sure that bond, that relationship, that structure, that trust is there within the first consultation, or you can't go anywhere and you can't continue, especially when it's something sensitive as well. Like something like I do when we're talking about fertility and making babies and families, and for you that you're treating people on a annual basis and their primary care, their rock in terms of their medical care. So I hear that, and I believe in it so much. These are such important things to address, and yet they're so simple, and that we shouldn't have had to be trained. I think it's things that should come innate. And I've seen these things on Instagram where they're asking a little kid that's looking at a picture of two kids, one is black and one is white, like, what are they doing? Like, the last thing the little kid understands or comments on is ever the skin color, which I thought was the most unbelievable thing. Like, innately, they didn't see that. They didn't even see that. So we have to begin teaching our kids from a very early age. I feel very, very fortunate. My kids go to a very diverse school that looks at complete diversity. They're everything in terms of race, in terms of LGBT communities are represented, and they don't think it's awkward at all for someone to have two daddies, two mommies, to be black, to be white, to be anything at all. Zero. And I love it. And I tell myself that, it's worth the amount of money I have to pay to get my kids into this school, because it's the absolute best thing they're going to ever learn for their future, more than the education itself.
That's so true, because their classroom needs to look like the world, you know, because we have to be comfortable everywhere, and we have to be open and inclusive to everyone, because all of us matter, right?
Everyone matters.
We've been preaching this for the last few weeks. Black Lives Matter. Trying to ingrain that all of us matter, and so that really starts at the the very early development. Because yes, biases are learned. We're not innately born to hate, right? We're not innately born to push people away. Humans are created to be connected, and so for us to exclude anyone, that's not in our DNA. It's just not.
Let me ask you on a different note. What advice would you give a reproductive aged woman who is a woman of color, a black lady in our country, who has not froze their eggs or embryos and not thought of their fertility?
Who's not thought of it?
Yes.
And they're what age now?
Reproductive age, like they're in their 30s and they have not thought about what they need to do to move forward with their fertility?
I think it should always be on our minds, right? In terms of what our plans are for our life. Because at the end of the day, as a woman, there is a finite amount of time.
Yes.
I do think that culturally, and this is also within the healthcare community, we put a lot more stress on women than is necessary, and a lot of negative stress in terms of, you got to get this done. You got to have these babies by 35, or you got to freeze these eggs by 35, and thinking that, motherhood is not possible after 35. So I do think we have to be cautious with that, because there's a lot of stress that we do put on women across the board that comes from us, right? So when I counsel my patients, because I do have a number of patients that come to me, and they get to me first before they get to you usually. And
yes, they do.
Yes, they do. And they're concerned, about wanting to start a family and wanting to do a lot of fertility tests before they even tried. And so typically what I tell them is, if you have not established that there is an issue, right? You haven't even found the partner yet, but you want to start doing a fertility workup. And it's like, okay, let's kind of slow our roll a little bit. Let's slow down, pump the brakes. Okay. So let's figure out, if we have to figure out if there is a problem. So usually I don't, and you're probably not going to agree with this, Dr. Ghadir, I don't push women to do fertility testing right away. What I usually recommend is that if you have been trying with your partner, and let's say it's been 6 to 9 months and there's no baby, then let's start looking into some other things. Let's start doing some blood work. Maybe we'll do some imaging studies. Perhaps I'll refer you to Dr. Ghadir, because I don't think it's necessary to jump the gun when we haven't established there's an issue.
I would agree, but I'm going to disagree with one thing. I completely agree, and being an alarmist is actually a really horrible thing. But I think that if someone's inquiring, a simple blood test like the AMH that allows us basically just to be able to check and see, okay, you're good, go try it for 9 months, versus like, okay, wait, before you get going and you leave my office now, I do want to let you know that the level is rather low. So I think that's also important to not forget. So it's a fine line of being extra cautious, because I'm in this industry and that's what I do, versus someone who's there for their patients and consoling them and being like, relax, you're going to be okay, there's help out there when you need it, but why don't you just relax and go try for a little bit. So I think there's validity to both. I think some people would feel better just knowing that their AMH and their egg reserve is great, and I feel some other people, like, it would just scare the hell out of them and just throw them off immediately as well.
Right. So like you said, it's a fine line. So I think you can go either way, and here again, I think is where you kind of have to read your patient a bit, and what do you think is going to maybe send them off the deep end and not be helpful.
Yes.
Because the other barrier
to pregnancy, it doesn't take much these days. It doesn't take much these days.
Exactly. We're all triggered right now. And so one of the things that certainly is a barrier to pregnancy is stress. So I would not want to put my patient in a position where they're going to be more stressed out, about having a child or what have you. But I can certainly see where, doing AMH or doing a simple blood test would not, be over the top. I think you can go either way.
Yeah, I think so. I love the comment that Allison, it looks like, just sent in, that I wish my doctor would have checked my AMH instead of saying I was fine when I wasn't. I lost almost a year. So I think I think that, so it's true. I think it has a lot to do with the patient, but maybe the good way that both of us have a compromise on this is be like, I don't think it's a problem, but if you'd like for me to order you a blood test, I can order a simple blood test and then follow the lead of the patient. So in a situation like that, I think it kind of leads the person to be in charge of their fertility.
Yeah. And there again, that's an excellent comment, because that's where, the communication is key. You want to bring the patient in as a partner in the treatment. It's never a dictatorship. It's never that. So when you allow the patient to kind of help guide you as well, I think that's when, you really get the best outcomes.
Yeah, absolutely. I agree 100%. And that's really important. I was going to let everyone know that Southern California Reproductive Center is having our webinars, and I have one coming up. I think it's next week. It's completely free. If anyone is wanting to watch the webinar, all they have to do is go to our website, SCRC-IVF, and sign up, and you are able to be on the Zoom with us all from your peaceful home. So it's easy for everyone to do that these days. I wanted to say thank you so much. I appreciate you doing this with me. I have so much respect for you as a physician, as a human being that I've known for a really long time, and as an excellent, just overall human being, and also mom. So it's nice to see you, and I can't wait to be able to come over to your office like I did occasionally and get back to the way we used to do things.
Yeah, well, love to have you, and I feel the same way. I certainly respect
Thank you so much.
and that's why I send patients to you all the time.
Thank you, my dear. I appreciate it. Stay safe, be well,
You
and
too.
thank you again.
You're
Bye-bye.
welcome. Take care.
Bye-bye.
Okay, bye-bye.